I'm very pleased to introduce our next speaker, Dr. Nadine Palermo. She's instructor of medicine at Harvard Medical School and associate director of the acute diabetes care at the Division of Endocrinology, Diabetes and Hypertension at Brigham and Women's Hospital. And Dr. Palermo is going to talk about a very critically important topic, management of diabetes in COVID-19. Take it away, Nadine.
Thank you so much for the kind introduction, and it is my great pleasure to be here to share this with you today, as management of diabetes in critically ill patients with COVID-19 has become an extremely important topic. Okay, so I don't have any disclosures to report, and I'd like to start with a case. So a 53-year-old female with hypertension, hyperlipidemia, and diabetes who's presenting to the emergency department with shortness of breath. Her symptoms began about 12 days prior to presentation, at which time she was tested for COVID-19 due to concern for a work-related exposure. At that time, it was negative, but over the subsequent weeks, she developed sore throat, diarrhea, fever, progressive dyspnea, and her repeat SARS-CoV-2 testing was now positive. She was started on azithromycin and hydroxychloroquine and quarantined at home until symptoms worsened and she presented for acute care due to increasing fever and anorexia. By the time she arrives in the emergency department, she was ill appearing, unable to speak in full sentences, and her oxygen saturation was 78% on room air. Biochemical evaluation was notable for normal renal and hepatic function. Her glucose on admission was 151, bicarb 20, lactic acid 1.2, and a pH of 7.41. Was also notable for elevated inflammatory markers, and her X-ray was concerning for bibasilar consolidation, concerning for COVID-19 pneumonia, and she was admitted to the special pathogen unit. Shortly after admission, she had increased oxygen requirement, now up to 15 liters, and was transferred to the ICU and shortly after intubated for hypoxemic respiratory failure. A little bit about her diabetes history. She has a long-standing history of diabetes and no known diabetes-related complications. Her pre-admission hemoglobin A1C was 7.5%, and she was on several medications for diabetes, including metformin, glimepiride, empagliflozin, exenatide, and glargine. She was compliant with all of her medications, including taking them the day of presentation to the emergency department. And as per our usual protocol, all outpatient medications were discontinued and she was started on insulin therapy on admission. Of note, glycemic control was at goal with minimal insulin requirements within the first 24 hours of presentation. However, over the subsequent 24 hours, she developed a metabolic acidosis with an elevated anion gap, glucose now rising to 192, bicarb deficit of 15, pH of 7.24, and a lactate of 1.3, with a beta-hydroxybutyrate of 6.1. She was started on IV insulin and dextrose support for treatment of euglycemic ketoacidosis. And after resolution of all of her metabolic derangements with ketoacidosis, she was treated with IV insulin. And of note, while she was in the ICU, she had very variable insulin requirements. This is a graph of some of her glucose trends and insulin requirements just even over a few days. And what you'll notice is that they were very variable, 3 to 28 units an hour, even over the course of a day, which was very common with COVID-19. So some of the things I'd like to touch upon this morning are really the clinical implications for patients with diabetes during the COVID-19 pandemic and some unique considerations in management strategies for those patients who are hospitalized with hyperglycemia in the setting of SARS-CoV-2 infection. So it's no surprise that patients with comorbidities and hyperglycemia are very common in those who are hospitalized with acute illness. And what we do know from a lot of literature is that hyperglycemia and diabetes were independent predictors of morbidity and mortality in SARS infections in general. So it was no surprise that patients with diabetes and other risk factors were actually at increased risk of complications in the setting of COVID-19. And time again, there is ongoing everyday new literature comes out evaluating other risk factors for severe illness. But what we do know is that for patients with diabetes who are hospitalized for COVID, it does increase the risk of complications of SARS-CoV-2 illness, COVID-19, increased risk of ICU admission, increased risk of mechanical ventilation, and even increased risk of mortality. So again, I can easily spend even an hour just talking through all of the literature. I want to highlight just a few studies to give you a spectrum of what we know about diabetes and COVID-19 for patients who are hospitalized. And these are two of the larger trials, just to paint the picture that there are several risk factors that we've identified to increase your risk of severe infection, namely older age, male gender. The question about whether or not pre-admission glycemic control is going to influence the mortality, again, is ongoing. Some studies have shown those with poor glycemic control coming into the hospital have worse outcomes. Some have showed no correlation with pre-hospitalization glycemic control. But what we do know is that those patients with other comorbidities, including micro and macrovascular complications, tend to do worse. And what is also really important is if you think about who are the patients who are coming into the hospital with hyperglycemia. So it really represents three patient populations, right? Those with established diabetes, those with previously undiagnosed diabetes, and those with stress hyperglycemia, or those patients who have no prior history of impaired glucose intolerance, and really just hyperglycemia in the setting of acute illness that resolves after the illness resolves. But the story is a little bit different with SARS-CoV-2, and we are seeing hyperglycemia in patients with all of these categories. And why is that? Why does that happen? So dysglycemia and COVID-19, there are many speculations as to exactly what is contributory in what we're seeing. But we do know that this is very common, even in patients, again, with and without a prior history of impaired glucose intolerance. Some of the leading theories, of course, due to overall metabolic inflammation, this enhanced release of cytokines and cytokine storm certainly plays a role in the pathophysiology, but there may be a unique component of SARS-CoV in actually pancreatic beta cells. And this is just some data back from 2010, looking at the binding of SARS-CoV in pancreatic islets. So one of the theories that are more speculative now, specifically to those patients who develop worsening of diabetes, or new ketoacidosis, is really that there may be an element of beta cell dysfunction. This has not yet fully been elicited, but certainly something with ongoing research. So not just diabetes and hyperglycemia, but what we're also seeing in the hospital is that patients are coming in with ketoacidosis. And again, these can be patients who have never had any history of impaired glucose intolerance. And it's likely due to, again, multifactorial etiologies, many of which are probably cytokine driven. And one of the leading theories is really IL-6, driving a lot of the ketoacidosis that we see with COVID. That combined with what I just mentioned about perhaps some insulin secretory defects with interaction with pancreatic beta cells is one of the leading theories. And again, I think there's ongoing interest in research in this area, but it has not been fully elicited, but is certainly a potential explanation for what we're seeing clinically for patients who are hospitalized with COVID-19. So just to summarize, we've learned a lot of things, even in a few short months with this pandemic. And the patients who appear to be most at risk for severe complications who are hospitalized tend to be those with advanced age, male gender, increasing comorbidities, obesity, and of course, with diabetes, you often see the diabetes, hypertension, cardiovascular disease, which has been shown in several studies to contribute to poor outcomes. One thing that we do know from the literature is that while it hasn't been fully characterized the importance of glycemic control prior to admission, there is a multitude of benefits of achieving glycemic control once patients are admitted. This was one study looking at patients with COVID-19, both with and without diabetes. And what is really striking is that the mortality was very high for patients who had uncontrolled hyperglycemia during their hospitalization. So just one study in support of what we already know, that controlling glucose in the inpatient setting is important, is equally as important in COVID-19. COVID-19. And there are several studies that are also showing that the glucose on presentation can also predict mortality. So big picture for right now is I want to underscore and highlight the importance of that once patients are admitted to the hospital. In addition to all of the other many aspects of their care during COVID-19 hospitalization, glycemic control is of utmost importance. But this is not as easy as it sounds. For patients with COVID-19, we are seeing tremendous variability in insulin sensitivity over the course of illness. This is common for patients with other respiratory viruses, but what we're seeing with COVID-19 is not even just daily variation. In some patients, it's even hourly, similar to the patient that I shared previously. Can also be challenging for patients with pre-existing kidney disease or acute kidney injury in the setting of SARS-CoV-2, which can also increase your risk of hypoglycemia. And again, this variability is seen regardless of glucocorticoids and vasopressors. There is definitely something unique about COVID-19, which can make management challenging in the inpatient setting. So how do we do that? We know that it's really important, and often the standard of care is IV insulin therapy. That requires frequent glucose monitoring, often hourly adjustments, which can be challenging in the setting of a pandemic. So how do you balance the importance of achieving glycemic control with frequent glucose monitoring and preserving personal protective equipment and reducing hospital staff's time at the bedside? And this is something that is of extreme interest, especially among the inpatient diabetes community. So the recommendations right now is that our patients and any patients with glucose over 180 or known diabetes to check a hemoglobin A1C on admission. Again, in patients that the A1C may not be as reliable, there are alternative methods that we can think about to reflect pre-admission glycemic control. Glucose monitoring should be done just as it is for all patients in the hospital, for those who are taking PO before meals and bedtime, or 4 to 6 hours if NPO. And then those who are requiring more intensive insulin therapy in the intensive care unit with IV insulin every 1 to 2 hours, or with intensive subQ insulin, which we'll talk about in a few minutes, every 2 to 4 hours. It gets even a little bit more complicated. So the standard of care is that point of care glucose testing should be done with hospital calibrated glucometers, and that continues to be the standard of care. But in the setting of a pandemic, where you're trying to reduce, again, time at the bedside, personal protective equipment, as well as transmission of the virus, there's also been other strategies that have been considered, namely using patients' personal glucometers, as well as continuous glucose monitors, or CGM. And I'd like to just point out that these devices are currently not approved for inpatient use, especially as the evidence to date in non-critical care setting. It's an ongoing interest in a lot of studies, but it can be very helpful in non-critical care areas to reduce the frequency of hypoglycemia. However, it's a little bit challenging because there are some glucose levels which may not perfectly correlate in critical illness and fluctuating pH status, which is very common in critically ill patients hospitalized with COVID. That being said, on April 1st of 2020, the FDA approved the non-invasive remote glucose monitoring devices to be used as an adjunct in the hospital setting, really to help with directional guidance, with the caveat that there may be limitations in patients who have altered perfusion, medication interference, and of course, those undergoing radiologic studies. This is, I think, something that we're going to hear more about. Again, there's ongoing studies, but I will just say that it's not as easy as putting on a continuous glucose monitor. There has to be appropriate infrastructure in the hospital and staff education and support of these devices. And currently, many of them are not integrated with the electronic medical record. And similarly, just to touch upon insulin pumps and closed loop therapy for COVID-19, currently, if the patient is able to self-manage their insulin pump, the recommendations are similar to that in the pre-COVID era, that patients can continue to do so. with the advancing diabetes technology, hybrid closed loop systems, namely where the CGM can feed data back to the insulin pump to adjust the basal rates, this can be challenging if you're unclear as to the accuracy of the CGM data. In most patients coming into the hospital, we generally recommend them changing to a manual mode if they are safely able to continue their insulin pump therapy. As far as non-insulin agents go, similar to the pre-COVID era, we often recommend discontinuing most oral medications, so discontinuing metformin for fear of metformin-associated lactic acidosis, sulfonylureas for hypoglycemia, TZDs for fluid retention, GLP agonist, again, most patients do have fluctuating PO status in the hospital, and this is generally not recommended. And the DPP-4 inhibitors, while their use in the inpatient setting has become increasingly popular, of note, there is concern that the DPP-4 enzyme has been identified as a co-receptor for MERS-CoV-2, but at this time, there's no data that shows that it's either harmful or beneficial in patients with COVID-19. But general consensus is still to stop these medications and focus mostly on insulin therapy, which is what I'd like to just summarize for us for the rest of our time together. So there are many ways to deliver insulin therapy in the hospital. And as I already alluded to, the standard of care for critically ill patients has been the use of IV insulin. This is a very effective means to achieve glycemic control. However, it is time and labor intensive. So in a pandemic, there has been ongoing interest for alternative strategies to IV insulin that can be useful for critically ill patients, especially those with hyperglycemic crisis. As I mentioned, the prevalence of DKA in patients with and without diabetes has increased for patients who are in the hospital with COVID. So thinking about alternative ways to do this can be very helpful. Prior to COVID, now even more than a decade ago, we have evidence-based strategies using subcutaneous protocols for mild to moderate DKA, as well as critical care for patients. And this can be a particularly useful strategy in the setting of a pandemic. So one way to think about it is after categorizing the patients and stratifying by severity of ketoacidosis, by pH, and by bicarb deficit, you can consider treating patients with an alternative strategy, subcutaneous insulin as opposed to the traditional IV insulin, as well as treating in an alternative unit. Perhaps not every patient with hyperglycemic crisis needs to go to the intensive care unit and can be treated in alternative areas. And again, this was all pre-COVID, and there are many strategies showing that this can be very effective, both in terms of treating ketoacidosis, as well as resolution, as well as decreased risk of hypoglycemia. And in addition to rapid-acting subcutaneous insulin given every 1 to 2 hours, there are also several studies showing the use of early basal therapy can actually decrease the risk of rebound hyperglycemia, particularly in patients who are critically ill, as well as those with ketoacidosis. So what I mean here is giving a dose of long-acting insulin up front, in addition to the insulin infusion, early can be helpful to minimize some of the variability like we saw in the patient that I presented previously. So thinking about all of these things together, there are many different institutions and many different protocols, and I'd just like to share one strategy that we use at our hospital, which takes into account some of the evidence for the rapid acting every 1 to 2 hours insulin, as well as the idea of early basal therapy as an alternative strategy to IV insulin in patients who are hospitalized with COVID-19. So what you'll see here, and if anyone would like to take a look at it, I've included the references so you can take a closer look at the protocol. But the idea behind this is to allow for high dose insulin therapy distributed throughout the day to address some of the unique concerns we are seeing with COVID, the rapidly changing insulin sensitivity and resistance, yet the need for high dose intensive insulin therapy. And this is just, again, walking through the protocol and thinking about some ways that we might be able to both initiate insulin as well as adjust insulin. And I'll tell you just from our experience, it has worked quite well as an alternative to the traditional IV insulin therapy. Similarly, you can consider this approach for ketoacidosis. It's using a very similar strategy with basal insulin up front and rapid acting insulin given every 2 to 4 hours, which can be, again, a useful strategy to think about in the setting of a pandemic. So going back to our patient, just our 53-year-old female with hypertension and hyperlipidemia, type 2 diabetes, who came into the ED with shortness of breath. She was treated for euglycemic DKA, had variable insulin requirements, again, 3 to 28 units an hour, even over the course of a day. And when she was transitioned to a subcutaneous regimen with Q4-hour insulin dosing and glucose monitoring, and I'd just like to share from this one case, this was a useful strategy to think about as an alternative to IV insulin, where we can safely achieve glycemic control, minimize time at the bedside, and preserve personal protective equipment. And it's equally important to think about patients even after you've achieved glycemic control to address what happens when they leave the hospital. So several patients with diabetes coming in may have complicating factors, maybe new to insulin, patients presenting with new diabetes in the setting of COVID-19. It's really important to think about the education for them in the hospital setting, as well as having a safe transition of care plan for them to when they leave the hospital. And telemedicine has been an extremely helpful adjunct for us to be able to continue to provide close follow-up and education. And this is true both for patients who are hospitalized with COVID-19, as well as those who are presenting to the emergency department with either worsening of diabetes or new diabetes with COVID, to be able to safely have continuity of care. It's important to think about making sure patients have adequate medications and testing supplies, and again, follow up with their diabetes team. Here are just some resources for COVID in diabetes. This is one from our hospital, and the COVID in diabetes over here is actually international resources for both inpatient and outpatient care of patients with diabetes, which I'd like to pass along and hope that it can be helpful. So perhaps we can talk about some questions, and then we'll have time to answer some of your questions. So which of the following has been shown to influence mortality in patients with diabetes and COVID-19? A, glycemic control during hospitalization. B, metformin use prior to admission. C, angiotensin receptor blockers and ACE inhibitors prior to admission. DPP-4 inhibitors prior to admission, or E, all of the above. Okay, great. So it looks like most picked A, glycemic control during hospitalization, and a few for E, looking at metformin prior to admission, ACE and ARBs and DPP-4s. So to summarize, the correct answer is A. So glycemic control during hospitalization has been proven in several studies to be an important influence for mortality, and those who have better glycemic control have better outcomes during their hospitalization and, of course, afterwards. Metformin use prior to admission, interestingly, again, although the data continues to come in, has not been shown to have any detrimental influence in mortality. And some of the most recent trends actually show that those patients who have metformin prior to admission may actually be protected. There are some theories that it may be due to AMP kinase related viral entry. I think the jury is still out, and stay tuned, but definitely not something that has been shown to increase mortality. Similarly, with ACE, ARBs, and DPP-4 inhibitor, most of the larger studies have not shown any correlation between prior to admission use and mortality for patients. So the correct answer is A. Okay, next question. 87-year-old female with longstanding history of type 2 diabetes who's admitted with COVID-19 pneumonia. Her hemoglobin A1C is 8.5%, and her home regimen for diabetes includes metformin 500 milligrams twice daily, glipizide 5 milligrams daily, linagliptin 5 milligrams daily, and insulin degludec 12 units nightly. Her labs on presentation were notable for glucose of 450, bicarbonate of 16, beta-hydroxybutyrate of 3.5, pH of 7.27, lactate of 0.8, and a creatinine, which is elevated to 1.7 from baseline of 1. Which of the following may be a strategy to consider for insulin therapy? A, correctional insulin only. B, restarting her home medications. C, IV insulin. D, subcutaneous insulin every 2 to 4 hours. E answers C and D, or F answers A and B. Okay, so the correct answer here is C and D. And I will say the caveat is that all patients with diabetes who are hospitalized, you should individualize therapy, but it's most likely that choice A, correctional insulin only, is not going to address the fact that her glucose derangements are definitely disproportionate to what we would expect based on her hemoglobin A1C of 8.5%. So her labs actually do reflect moderate DKA, so correctional insulin only would not be sufficient to correct the metabolic derangements. Restarting the home medications would not be advisable, again, in the setting of potential changes with her renal function, as well as the metabolic acidosis. We would definitely hold on many of those medications, particularly those that would cause hypoglycemia. Using IV insulin or subcutaneous insulin could be considered. So again, this is a patient with ketoacidosis, so the traditional IV insulin is always a correct answer, but for her, because this is otherwise mild or moderate uncomplicated ketoacidosis, you can consider an alternative strategy with subcutaneous insulin, as I discussed previously, as an alternative which may be helpful, particularly in the setting of a pandemic, to increase the interval of glucose monitoring, medication administration, and preserve PPE and minimize staff time at the bedside. Perfect. So just as we're finishing up in summary, I'd like to just continue to highlight that glycemic control during a hospitalization, particularly with COVID-19, is extremely important. And there are alternative strategies to treatment for patients who are critically ill with COVID-19, including the use of subcutaneous insulin as an alternative to IV insulin. And there is again, much interest and further research is needed to really understand both the incidence and pathogenesis of new diabetes, DKA, or worsening of existing diabetes with SARS-CoV-2. But I am very optimistic that we're going to learn more, and I look forward to being able to share what we learn in the future. So thank you so much for your time and attention this morning. And I'm not sure if we have time for questions now, or we can save them for later.
Nadine, I think since you're going to come back for questions, we're about out of time, so we'll hold the questions till the Q&A. But thank you for a wonderful compilation of your own experience and the literature in this rapidly changing field. I think you were working on this up to the last minute to get everything in there, and also appreciate your care of these very sick patients during this pandemic. So thank you so much, and we'll see you back at 12:30.